Hello, Andrew Wolf here. In this video I'm going to be talking about the pathophysiology of arrhythmias. So arrhythmias are rhythms of the heart that are either too fast or too slow or irregular. So typically the heart beats at a regular rate between 60 and 100 for an adult. And for kids it really sort of varies by age, although all heart rates are normally regular. So any kind of irregularity is abnormal. Okay, so there's two basic types. There's rhythms that are too slow, bradycardia, or bradyarrhythmias, and tachycardia. Okay, so we're going to talk about bradycardia first. So, bradycardia. Let's stick with the blue color here. So bradycardia there are two possible causes for bradycardia. Remember, we have the heart here, and the chambers of the heart, here, let me just kind of color this in here. A nice big red heart here. And now the chambers of the heart, obviously, are divided into four sections. Now, the right and the left sides of the heart are sort of divided by myocardial cells, and myocardial cells are conductile, so it is possible for conductile tissue to go between the right and left atrium and the right and left ventricles, and vice versa. However, the atria and the ventricles are divided by valves. And there's two valves for each, right? And these valves are made up of and surrounded by cartilage. So each valve has, its leaflets in here, and then it has what's called an annulus, which is a ring around it, and that ring is made out of cartilage. Now, the valves and the annuli of the valves create a cartilaginous or a barrier of connective tissue separating the atria and the ventricles. This is very important to understand when we're talking about arrhythmias, because one of the things, now remember, we have an SA node up here, and I'm making it a little big. And the SA node is in a normal heart rhythm, the pacemaker of the heart, and it sends out, it starts and initiates the action potential of every heartbeat. And then we have an AV node here, and the AV node is the only pathway in a normal heart in which the action potential can pass from the atria down into the ventricles. Now, the AV node actually slows the conduction so that there is a delay between atrial contraction and ventricular contraction, but it generally passes it by quite effectively. So there are two possibilities. There are two things that can cause bradycardia. Number one is the SA node is either slowed generating action potential at all, so absent action potential. Now, why is it slowed? Well, most frequently the reason why it is slowed is because it's getting less sympathetic impulses, so less sympathetic nervous system impulses, or it's getting more parasympathetic, and that those actions will slow the SA node. Other possibilities are the SA node may be damaged, so that may slow it, or it may make it so that it is no longer the pacemaker of the heart. Now what happens if it's not the pacemaker of the heart? Then some other pacemaker may need to take over. The AV node could take over, and then we will have what's called a junctional rhythm, and which is all well and good, but the AV node as a pacemaker is much slower. It makes a heart rate of about 50 beats per minute. Now, if the AV node is not working as both the SA node and the AV node is not working as a pacemaker, then the pacemaker cells in the ventricle or the Purkinje fibers will take over, and then we'll have a very slow ventricular escape rhythm, and the heart rate is usually around 25, which is just barely enough for a life-sustaining for a patient at rest. Okay, so that's one cause of bradycardia. Another cause of bradycardia is blockage of conduction from the SA node. The most common place of blockage is dysfunction of the AV node. Now, this may be caused by ischemia or fibrosis from a prior MI, or from myocarditis, from viral infection, or anything that can damage the myocardium can damage the AV node. And what this will end up, what we'll end up with is a heart block. And I'm not going to get into all the details, but if you remember from sort of your early nursing courses, there are three types of heart blocks, and they all involve dysfunction of the AV node to different degrees. Okay, so there's a first, second, and third degree heart block, and it all just depends on how dysfunctional the AV node is. Now, we also can have what's called bundle branch blocks. So if we have a blockage, in the left bundle branch, so if we have a left bundle branch block, this will block the conduction of the heart. And however, if we have a complete blockage of the left bundle, we're not going to have any passage of conduction through the bundle branches to the left side of the heart. However, because there is no cartilage between the ventricles, what we get is action potentials moving from the right to the left. So this does slow the depolarization of the ventricle, which is why we end up with a widened QRS complex, but it generally does not slow the heart rate, because the action potentials are able to cross the ventricles. So it's really only things that deal with the AV node that prevent the action potential moving from atria to ventricles that can cause bradycardia. Okay, so tachycardia. Tachycardias have three major causes. The first is going to be increased pacemaker activity. So we're going to have increased pacemaker activity in the SA node. What causes this? Well, again, the most common cause is going to be input from the sympathetic nervous system, right? Fight or flight or exercise, things like that. That is going to naturally increase the heart rate, so that will cause what's called a sinus tachycardia, because it develops from the sinoatrial node. Or it could be caused by a decrease in parasympathetic tone. Or it could be caused by dysfunction of the SA node, for instance. So SA node dysfunction. And one example of this is called sick sinus syndrome. Now, sick sinus syndrome is an interesting illness. It's just dysfunction of the sinus syndrome that can cause tachycardia, and it also can cause bradycardia, and generally people sort of swing back and forth, and it's just because the SA node is damaged and kind of swings back and forth from being overly excitable and underexcitable. Okay, and number 2 is going to be reentry tachycardias. Now, one example of this would be atrial fibrillation. Now, if you imagine, usually the action potentials flow in a straight line from one direction to another, right? So we have these sort of general pathways. But if we have something that disrupts this pathway, you know, if we've got some kind of scar tissue or something slows or blocks that tissue, what happens is the action potential is going to travel around it, which is fine. However, there's sort of tissue in here around it that has not been depolarized. So what you're going to end up with is sort of this circuit, and this as this travels backwards, this tissue here will have time to repolarize, and you'll end up with this circuit here where you have depolarization and repolarization happening very, very quickly, and this can happen 300 to 600 times per minute. Now, what happens is this sort of forms an ectopic foci because there is damaged tissue here, and you end up with a circuit. The wave of depolarization keeps going around in a circle, and this can happen in in several different places within the atria, and this can happen just sort of with age, as sort of scar tissue forms, or there's damage to myocardium over time, or it can be prompted by illness. Now, the same process can also happen in the ventricles and can lead to either ventricular tachycardia or ventricular fibrillation. So that's one example of reentry tachycardia. So AFib. And then ventricular tachycardias can also be caused by that. And these tend to be usually they're paroxysmal. And another type is another type of reentry tachycardia that's very famous is called Wolf-Parkinson White Syndrome, or WPW. With Wolf-Parkinson White Syndrome is very interesting. It actually, now remember I told you that in a normal heart we have the cartilage of the valves and the annular rings around the valve completely separate the atria and the ventricles. But what happens with people with Wolf-Parkinson White Syndrome is there is a deformity in the annular ring of the valve, or a deformity of the muscle that sort of grows over the valve, and you end up with an alternate pathway. So Wolf-Parkinson White is due to an alternate pathway between the atria and ventricles. Okay, so what happens? Okay, well, the first thing that happens is some of the action potential is not going to get delayed in the AV node, because remember the AV node sort of acts as a conduction delay. It slows the action potential down for a couple tenths of a second to delay the contraction of the atria from the contraction of the ventricles. But if we have this alternate pathway here, the ventricles, parts of the ventricles begin to get depolarized a little bit faster. Okay, so that's step number one. Then step number two is the waveforms that do go through here depolarize the ventricles and then come back up here and depolarize the atria too quickly. So we end up with an EKG that looks like this. We have a P wave, and then we end up with the start of our QRS with a slope, and then it's normal. We have our T wave, and then we have premature atrial contraction, sloped Q wave that starts prematurely, and a QRS. So what's this? So the PR interval here is very short. Usually it's between 0.16 and 0.20, and in Wolf-Parkinson white it may be, as low as 0.8 or 0.4. But it's, and this represents the depolarization of the ventricle that starts here because of this accessory pathway. And it starts out sloped because not all the ventricles are only being partially depolarized early, so you end up with this sort of what's called a slurred QRS. And then what causes the premature atrial contraction? Sometimes you'll see these random P waves so you'll see the slurred QRS T, and then you might just see a random P wave that does not trigger a ventricular contraction. And sometimes you'll see premature atrial contractions, and this is just occurring because of this repolarization of the ventricle through that alternate pathway. Okay, so that's Wolf-Parkinson white, and this can lead to sometimes there's premature atrial contractions every now and then, or it can lead to tachyarrhythmias if the ventricles are depolarizing the atria with every heartbeat. Okay, so that's reentry tachycardias. The third type is delayed repolarization. Now, why is this a problem? Well, remember, if you look at the normal action potential of a myocyte, you have your resting potential here, then you have rapid depolarization, and then delayed repolarization from the calcium channels. Now there are some conditions that can delay the repolarization even further. So what you end up with is a situation like this. Okay, so this is delayed repolarization. And this can be caused by a number of conditions. This can be caused by heart cells that have been damaged by ischemia. It can be caused by a number of medications, or it can be caused by electrolyte imbalances. Particularly, magnesium, potassium, and calcium. So you will note this on an EKG by, all right, let's draw the little EKG here. So we've got our P wave, normal PR interval, QRS complex, and then a very long delay before repolarization. So this is what's called a prolonged QT interval. Now, a prolonged QT interval is dangerous because now generally there is a refractory period in which the heart cannot beat, the cells cannot be triggered with another action potential. However, with delayed repolarization, there is a period here where that refractory period is over, but the myocardial cells remain hypopolarized. Remember, because we have we're up to here at a negative 90 millivolts, and so they are actually in a hyperexcitable state and easily depolarized again. So you end up with a repolarization. Now this is what's called an R on T phenomena, where if you have an R wave that starts here on the T wave, it can trigger a tachycardia. R on T phenomena. Now what happens is, remember, these cells are hyperexcitable because they're already partially depolarized, so you end up having this RNT phenomena around a whole bunch of other hyperexcitable cells, so you end up with cells that are all sort of triggering each other, and you end up with all these circuits around the heart where each cell is repolarizing the cells next to it, and they're polarizing the ones next to it, and they're all repolarizing each other, and you end up with all these little circuits around the heart, and this causes ventricular fibrillation. Okay, so that's all I have on the physiology of arrhythmias. Please click on one of these links. You can either click to view my channel or click to subscribe to it. And I'll see you in some other videos.